And thanks everybody for those who have already introduced yourself. If you have not already, please feel free to do so in the chat. And I do want to confirm that slides are going to be available after the webinar on our website, as will the recording. And since we have a pretty big group on this call, please use the chat box and feel free to chime in. We'll have time for discussion at the end. But also, if you have comments, clarifications, questions, please feel free to use the chat box throughout as well. And with that, let's go ahead and dive in. I think most folks know me, but just in case, Kate Schroeder, I started at Interact for Health in January of this year as the president and CEO. And we're really excited to be here today. This is the second in a series of 4 webinars that we are going to be doing as we go through our strategic planning process. And I'm going to kick off today here going through where we are in the process, overview of the timeline, what we're hoping to get out of it. And then I'm going to hand it over to my colleagues. Kelly Adcock is going to talk through listening to data and what we've learned from data over the past several months. And then Ross Meyer will talk through our insights from the conversations that we've had with many of you and community members. And then Ashley Young will be talking through where we're going. We expect this will take about 45 minutes or so, and then we want to leave time at the end for discussion. All right, so moving on to show you where we are in this process. So we are going through developing our next 5-year strategic plan. So many of you have worked with Interact for Health for some time. We've been around about 25 years now. And every 5 years, we've gone through a strategic planning process. So for the past 5 years, our priorities have been around smoking cessation, around opioid overdoses, reducing opioid overdoses, and then school-based health. And so this year, we are seeing through our commitments on those 3 areas. And at the same time, we're taking a step back to really revisit what are the areas and ways in which we can have the greatest impact over the next 5 years. And so outlined on this slide is the process that we're going through. We are at the bottom of that second column today. This is our July 21st webinar. We're really committed to being open and transparent in this process with our partners. We are here to serve our community, and we cannot do that without listening first. And so we've spent the last several months listening to data and listening to people, and we're going to be sharing out what are the main insights that have come out of those conversations and out of that data analysis. And also being really honest about our strengths and weaknesses as an organization. What are the ways that we see ourselves adding the most value based on the feedback that we're hearing? One of the themes throughout this has been run to criticism. We are here to serve, and so please continue. We so appreciate all the open and honest dialogue we've had through this process and look forward to that continuing. And after today, we're going to spend the next 3 months, really Q3 for us, is about prioritizing planning based on the themes that have emerged thus far, fleshing out where and how can Interact add the most value in that, and then towards the end of the year and early next year, really operationalizing and diving into our getting started in the new strategic plan. As a reminder, our mission at Interact for Health is to promote health equity. And for me, it's more than promoting, it is advancing. It is actually having health equity is a really major challenge in our region, as we'll see in the data and the feedback that we have heard. And this is what we want to hold ourselves accountable to. Are we making an impact on health equity over the long run in this community? And it's not about us alone as an organization. These challenges are bigger than any one of us. It's how can we serve and fill gaps, and as part of this broader regional community, help to advance and improve health equity. And on this next slide here, you'll see how we define health equity. It's when every person has the opportunity to achieve their full health potential. And no one is disadvantaged from achieving this potential because of social positions, because of where they live, or other socially determined circumstances. And there are really 2 parts of this. This is from a WHO definition. You have the health inequities that are disparities in rates that exist due to differences in the distribution of social, economic, environmental, healthcare resources. And then there's the disparities that come from that due to differences in health status. And so the combination of those is really what we're thinking of when we talk about health equity. So with that, I'm going to hand it over to Kelly to talk us through what we've learned listening to the data.
Awesome. Thank you so much, Kate, and thanks for everyone for being here. Like Kate said, I'm Kelly Adcock, and I lead research, evaluation, and learning at Interact for Health. It's an incredible honor to be here with so many amazing people in our community. There's so much incredible work already happening in our region to advance health equity and sort of move forward the vision and mission that Kate talked about. I'm going to share a lot about what we've learned from data in these past few months. Before I dive in, though, I'd like to say that the risk of sharing data in numbers is it's really easy to depersonalize it, just numbers on a screen. But I want to remind us that these data represent lives in our region, in our neighborhoods, perhaps even our own families. And so I encourage you to engage with these data, not just as an intellectual, interesting exercise, but also on an emotional level. We're going to go through the overview you see here of the regional health data. We set out to answer these key questions: who lives in our region? How long do we live? How well do we live? All while trying to get a snapshot of the disparities and the inequities behind these. So first, let's remember the people who live in our region that are behind the numbers. Interact for Health works in a 20-county region in Ohio, Kentucky, and Indiana. And in that region, we have 2.4 million people, including 500,000 children. Moving on, our region, as we well know in the green bars as our region, we're more white and less diverse than the nation in our gray bars. 85% of people in the region are white compared to 75% in the nation, 13% Black in the region, 14% in the nation, 3% Asian, 7% in the nation, 3% Hispanic, which is lower than the nation at 18%. And as you can see, moving on, just looking briefly, the distribution, the darker green areas on the map, you can see that the Black population in the region is highest in our urban and suburban areas, with 28% of residents in Hamilton County and 44% in the city of Cincinnati are Black. Moving on to the overview of looking at how long we live. So life expectancy is a key metric for population health, for assessing and capturing mortality across the entire life course, telling us the average age of death in a population. So we learned that people in our region live shorter lives than people in the nation. Regional life expectancy, it's the bottom green line that you see here, been relatively flat and below the national average, the top gray line, by about 2 years. So I want you to take a moment, think about where you were. I don't know if we want to think about it back in 2020, it's the start of the pandemic, but think about where you were 2 years ago and how much life that you've lived since 2020 in those 2 years. And that's sort of the gap in life expectancy between the nation and our region. We looked at what's causing death in our region. So the region, again, the green bars, we have a higher or similar death rate than the nation, the gray bars, for many of the top causes of mortality. Noted with a star, the region, though, has higher death rates than the nation for accidents, which is largely driven by overdoses, stroke, and Alzheimer's. Then we looked further at disparities in life expectancy. So Black life expectancy, the bottom yellow line, it's about 4 years below white life expectancy in the region, the top blue line, and that gap's widening. So again, I want you to think about 4 years ago, that was 2018. How much life have you lived since then? And then we looked at death rates, so disparities in death rates. Black residents, yellow bars, have a higher death rate than white residents in the region, the blue bars, for 5 of the top 10 causes of death: heart disease, stroke, COVID-19, diabetes, and kidney disease. And then we looked even deeper at differences in how long people live across our region, looking at that county level, and we see a 7-year difference between Warren County with the highest county with a life expectancy and Pendleton with the lowest life expectancy in our region. Think about where you were 7 years ago now, back in 2015, and how much life you might have lived since then. And then even the county level, that's not good enough, so we disaggregated the data even further by geography, and found that in our region, life expectancy can vary by about 26 years between when we look down at that census tract level. So those areas in yellow have the lowest life expectancy in our region, with a census tract that's in Indian Hill having the highest life expectancy at about 88 years, and a census tract that's in Western Newport having a life expectancy of about 62 years. So that's 26 years, and that's 1996. So think about how much life you might have lived since 1996. So I know that's a lot, but knowing that some people, some places in our region have been left behind, we asked what could be behind this. And this took us to examining some of the factors that impact health and well-being. And many of those, while it's estimated that healthcare might make up about 20% of a person's health, research shows that 80% is driven by factors like economic stability, education, our social and community context, neighborhood and built environment. But I do want to highlight most importantly that through line of that you see across the middle of racism and discrimination and its role in driving these disparities in health outcomes, things like mortality, the life expectancy we just talked about, and health status. So we could spend a few hours together diving into all of these, but just to give a brief snapshot of how these might be playing out. Do you recall this map that I just showed with the yellow places with the lowest life expectancy, the lowest quartile in our region? So we looked at that, and then we looked at those with the highest life expectancy, the highest quartile. And we found that compared to residents with the highest life expectancy, so you're looking now at the top row of the table here, compared to residents in census tracts with the lowest life expectancy, this bottom row of the table. They're more likely to be younger. That median age is 37 years in the lowest life expectancy areas compared to 41 in highest life expectancy. More likely to be Black or Hispanic. In places with lowest life expectancy, 32% of the population is Black, 5% Hispanic, compared to 7% and 3% respectively in highest life expectancy areas. More likely to have less income. Median household income of almost $39,000 in places with low life expectancy, and $94,000 is the median income in the highest life expectancy areas. And folks in lowest life expectancy areas more likely to rent and not own a vehicle. So in short, place and race matter to our health. There's a 2-year gap between our region and the nation, a 4-year gap between Black and white residents in our region, 7-year gap when we look at the county level, and then that 26-year gap between our census tracts. So looking at quality of life, so we just looked at how long people live. So we're trying to, thinking about how do we save lives, how do we add years to our lives, and that's important. But improving quality of life, sort of adding that life to our years, it's also critical for us to get a bigger picture of overall health. Quality of life can tell us a lot about how people perceive their own health. When more people in a community say, hey, I'm not feeling healthy, it can influence other factors like mortality rates, unemployment, poverty, etc. Tells us a lot about the well-being of a community and our physical, mental, and social health. As you can see here, we found that people in our region who say that their own health is fair or poor, that's how they perceive it when they wake up in the morning. That's not improved in the past 20 years here in our region, as you can see in that light blue line. So in 2022, about 1 in 5 adults in our region, almost 500,000 people, said that they are living in fair or poor health. It means they might be at higher risk for morbidity, mortality, and other issues. And people living in or just above the poverty line are bearing more of the burden. We also know that mental health matters to our quality of life, and it's important to individual and community health became abundantly clear over the past few years to all of us during the pandemic and the ongoing struggle for racial justice. You can see here that some people in places report higher levels of frequent mental distress. So while about 17% of adults in the region in 2022 reported frequent mental distress, you can see some of the disparities. Nearly half of LGBTQ plus folks in the region, a third living in poverty, and a quarter of young adults and those living in our rural communities reported frequent, that's 14 or more days a month, mental distress. And as many of you know, access to treatment and the workforce issues surrounding it continue to be issues in our region. And then that's adults, but we've all seen the headlines, right? Especially here locally, nationally, around how young people are struggling with their mental health. Nationally, we know that about 1 in 5 young people experience a mental health disorder like anxiety, depression, substance use. We saw increased use of the ED during the pandemic for youth that are having mental health emergencies, including suspected suicide attempts. So what you see here is a snapshot of local data that we have. We see the similar crisis playing out in terms of our youth experiencing stress, anxious feelings, a desire to be alone all of the time, emotions, depression, suicide ideation, and all these things either got worse or stayed about the same from 2020 to 2022. And then finally, rounding out quality of life, we also looked at premature death and some of the so-called deaths of despair. And we see that overdose, suicide, and homicide are prematurely ending many lives in the region. And many of the disparities we see in those are here on the slide. Our overdose rate, this is not a new story, but our overdose rate in the region is nearly 2.4 times higher than the nation. When we look at our suicide rate, we have a similar rate to the nation. But if you compare Black residents in the region to Black residents in the nation, we're about 1.2 times higher in the region than in the nation. And then astoundingly, our homicide rate might be about the same as the nation overall, but for Black residents in our region, it's about 13 times higher for Black residents than for white residents. This disparity also exists at the national level, but it's even more pronounced here. And I also just want to pause and connect this back even to the what we talked about with mental health and substance use issues and how those, along with all the factors that are impacting health, are sort of undergirding a lot of these issues. So finally, I know this is a lot of data, a lot of information, and it's hard to get through and hard to hear, but I do want to point out that we all know that Greater Cincinnati has some incredible assets, incredible people on this call and elsewhere, but we have a lot of work to do. There's a lot of opportunity for the future. So we know that we're lagging the nation. We can do better. We have not necessarily improved how well we've lived in the region. We can do better. Some people are in places that are lagging far behind. We know that many of the underlying root causes, the inequities, driven by conditions and systems in which people are born, grow, live, work, and age, are at the root of those. So I do want to pause even for a moment and just encourage you to maybe chime in on the chat. A lot of data here. What sticks out with you? How does it make you feel? Does anything resonate? And then I'm going to turn it over to Ross. We've talked a lot about data, and behind data are people, but he's going to run us through what we've heard talking to people in our community.
Good morning, everybody. Ross Meyer, VP for Strategy here at Interact. So very excited to be with this team and all of you on this journey to really deeply understand what we are facing, and that's a sobering story that Kelly shared, but also where are the opportunities for us together to make a measurable difference in changing those trajectories. So as we have been going through this strategic planning process, we've been very intent to, of course, look deeply at the data and disaggregate that data to understand the greatest health needs and how they have changed over time and for who. But we've also been just as intent at listening to you, listening to many of you who are on the ground every day, fighting the fight to improve the health of our community, as well as everyday folks in our community that are represented in those numbers that Kelly shared, who are experiencing health disparities and inequities. We've really been intent on listening deeply and centering the voices of those most affected in the process as we decide where can we together make the most difference. So we've been on quite a journey over the last couple months, and this is a summary of some of the key inputs that we have been bringing into our thinking to help us better understand the needs and opportunities. Many of you have been part of the Community Health Needs Assessment that was conducted last year, quarterbacked by the Health Collaborative. This was really an unprecedented effort, 26 counties, 36 hospitals, 22 health departments, and included over 10,000 inputs. That assessment and then the corresponding community health improvement plan, we've been very intent on not only aligning but identifying where we can make the most difference based on all of that tremendous collaboration and input that was gathered. So we pulled all of that forward into our thinking and our process as well. As many of you who joined us on our last stakeholder update, we shared the results from our grantee perception survey. This was conducted last year by the Center for Effective Philanthropy. It gave us tremendous insight as both our strengths as a grant maker and a partner and our opportunities for growth. Check out our website if you'd like to see more details on the findings of that. We'll share some of that as we share our SWOT analysis with you and really bringing forward where you told us that we could get better and the strengths that we should continue to leverage. We've talked to a lot of folks, many of you included, and others, key stakeholders, again, who are on the ground, partnering with us throughout the years in doing important work in our community. We've done 84 one-on-one interviews with key stakeholders across our region. Many of you also participated in our survey, stakeholder survey, 174 folks. You can see some of the demographics. Importantly, only about a quarter are current grantees. So we got a lot of great input from diverse voices across our region as to what are the greatest health needs and where can we, again, make the most difference. In addition to all of us who are working every day on improving health, we wanted to listen directly to the everyday folks in our community, the folks that are represented in the data that Kelly went through. So we've done that in a couple ways, and this is an area that we want to continue to build and grow to really center the voice, especially of those most impacted, most affected by the inequities and disparities that are making health farther from reach. So we've conducted, in partnership with Cohere, a series of focus groups specifically focused on the Black community, Latino community, rural folks, and low-income families to really understand deeply how they perceive the health of our community, where their opportunities to make a difference. We also joined with many of our partners in coalitions to engage in community conversations around our region, primarily focused on urban and rural communities, again, asking where can we make the most difference together on improving health. And Kelly already shared some of the data. As many of you know, we conduct on a regular basis the Community Health Status Survey in partnership with UC's Institute for Policy Research. That data was from just earlier this year, just a couple, April and May, a representative sample of 1,400 people across our region that not only gave us some of that data that Kelly shared, but we also asked from their point of view, what are the greatest health needs in our community? So the data that I'll summarize quickly for you comes from all of these inputs that we've gathered over the past couple months. First, I want to share the stakeholder survey. Again, this was 174 folks. Many of you hopefully participated. And one of the key questions that we asked is, from your perspective, rate the importance of Interact for Health addressing the following health needs in our community. And you can see many are clustered together, but no question, mental health for youth, mental health for adults at the top of the list. Which isn't a surprise given what we all know to be true, especially given how the pandemic has exacerbated the already increasing mental health crisis that many in our community was facing. Outside of mental health, you can see a bunch clustered around youth. Prevention, primary care access for children, ACEs and trauma, no surprise there that there's a unique opportunity for us especially to really focus on changing the trajectory early, building on our legacy of work with school-based health centers to really provide support and a good start for our young people. Substance misuse also hits the top of the list as well, no surprise, given how correlated it is with mental health and the continued challenge around overdose in our community. You can see social determinants are up there as well. Again, all important, but it's what's important for us out of this was mental health topped the list. Now, looking at data in the aggregate sometimes misses key insights. So we disaggregated that survey response by race and geography, and there's some interesting insights here that we wanted to share with you. By race, by the Black respondents versus white respondents, mental health for youth and adults was still number 1 and 2, which is an important finding. But the third in the ranking was interesting for Black folks, really pointing to racism and discrimination as a core issue undercutting a lot of the disparities that inequities that we're facing, whereas white respondents focused on social services access as the third highest rank. Interesting insights there. Black respondents also were more likely than white respondents to rank chronic diseases higher and give more weight to gun violence, which, given the dramatic 13 times higher rates of homicide that we're experiencing in our community that Kelly just shared, is not surprising, but also just as much a tragedy. On geography, we broke down respondents to really understand some of the disparities and differences from rural versus urban and suburban communities. Our rural folks ranked transportation higher than folks in Hamilton County, and suburban respondents, not surprising, transportation is a key barrier, a key determinant of access to health. Our rural and suburban respondents also ranked substance misuse and dental care access higher than Hamilton County. So if you recall the map that Kelly shared, dramatic disparities in life expectancy, especially in our urban and our rural communities. So understanding this data broken out for us helps us get a better understanding of folks that serve those communities, what are the top needs that they are seeing. So when we pull it all together, again, at the bottom are all the sources that we pulled into this analysis, the stakeholder survey that I just went through, the community health status survey, the community conversations and focus groups that we conducted, and the community health needs assessment. These themes really align and pop to the top. Mental health for youth and adults across every single source of input was really in the very, very top. And again, the data bears that out locally and nationally about the rising crisis that we're facing, that our youth in particular are facing. Social determinants, the underlying drivers of health, housing, racism, transportation, also near the very top of the list. Within healthcare itself, workforce, availability of workforce, the diversity and representation of that workforce, top issues that many cited, and including continued challenges around the affordability of healthcare, substance use prevention, of course, the lingering impacts of COVID, very much still true today. So these were the top issues, again, as we looked across all the sources that we brought into this analysis, really rose to the top, and a lot of consistency in what our community is telling us are the greatest health challenges that we collectively need to make progress on. A couple of quotes I want to share with you because in the actual words that folks shared with us, there's a lot more richness and insight. And this is from our stakeholder survey. If mental health was the only thing Interact focused on over the next 5 years, it'd be time well spent. Until Black and brown people do well, our city won't do well. No Band-Aids. We need systemic solutions for root causes. Keep a focus on rural counties. They have huge needs and very few, if any, other funding. Focus on prevention for the youngest children and their families to have the most impact. Workforce, pipeline, and diversity, a major challenge. Need providers who look like the patients served, and addiction, broadly speaking, not substance specific. A couple other quick quotes from our community conversations. that, again, I think really hit home. My son is struggling with some health issues, and because of this, I've started to have issues with anxiety and depression. I've gone several times to the clinic and asked for a psychiatrist, but they never found someone to speak Spanish with and can help me. First priority for me is housing, because once you have a place to lay your head, you're not worried about where you are going to sleep. A lot of things fall into place because that is what a lot of families worry about. So just a snapshot of many rich insights that everyday folks across our region shared with us. So I'm going to pivot now and share, in addition to the health needs, we also, in our stakeholder interviews and the community, the grantee perception report, that is, asked deeply for folks that have worked with us, what do we do well? And what can we do better? So we summarized that all in a SWOT analysis that really captures, as we understand them, Interact's greatest strengths that should be leveraged and continued, the weaknesses that we have to be very focused on improving, and the external opportunities and threats in the environment that we need to be aware of. Internally, on the strengths side, we heard time and time again that Interact's greatest strength is our independence. And our regional footprint, that we are neutral and we can bring partners together that few others can to focus on the big, hard issues. And that independence should be leveraged even more. Similarly, our funding can and should be more flexible, more responsive than other funding streams, and the flexibility of it and the responsiveness of it is a true value add compared to other more restrictive funding streams. Should be, again, leveraged even more so. Many of our grantees and partners commented that we go much beyond just being a funder, just being a check writer. The support we provide, the capacity building, the technical assistance, the expertise that our staff bring to bear are all tremendous value adds that should be continued. Our policy work, systems work, really elevated that we need to continue and just grow that, because that's where we get long-term lasting change. And finally, our regional focus, our footprint of our 20 counties, including our rural communities that are often underserved. Many folks commented that that's a unique value add. Weaknesses, though, that we heard clearly, especially in the past couple of years, have been a little too narrow. And one grantee in their grantee perception report said, I feel like I have to turn myself into a pretzel to be competitive for an Interact grant. And that just limits opportunities for us to really do important work together. The structure of our grants, we heard this clearly from our grantee perception report, which compared us against 300 other funders in the nation. The structure of our grants are shorter, they're smaller, and they're more restrictive than our peers around the country. And many in the field of philanthropy are really moving towards larger, longer term, more unrestricted grants to really focus on greater impact, longer term partnerships to really achieve the kind of change we want. So that we took that to heart, that we need to change the structure of our grant making to lead to more impact. Many commented in the past couple of years, we haven't fully leveraged that independent regional convener role as health, and we've been limited. We've been a little too go it alone, and we have to change that because we have a unique role to play in really partnering more deeply as a neutral convener on health. We've been too risk averse. Again, we have a lot of independence that we should leverage even more to take on the hard issues with courage where others might not be able to. And recently, we've had lack of clarity on our strategy and goals, and we need to improve on that. Opportunities and threats. On the opportunity side, many folks commented that, the COVID brought a lot of tremendous challenges, exacerbated a lot of the inequities that Kelly shared, also demonstrated what we can do together. When we work together, collaboratively, set aside competitiveness, and really focus on collective action, can get big things done. And the CHNA, as I shared with you as well, is a tremendous, unprecedented, a collaborative effort. Momentum should be built from both of those examples around doing more together. A lot of momentum we heard around the affordable housing space in our community. We know it's a key driver of health. More should be done to really take advantage and focus in on that momentum and connecting health and health systems, health sector to the affordable housing movement. A lot of money is coming into public fund to public health, and especially around the opioid settlement. Let's make sure we are coordinated and have a regional plan that's really addressing the key gaps. Threats, no question, COVID is still continues to be a significant threat and made worse made worse a lot of the deep inequities in our community. Workforce is top of the list as well, not just in health itself, but our nonprofit community partners as well, struggling with workforce really hampers our ability to get anything done. Lack of diversity among health providers and the ongoing mistrust with the health system, and especially through COVID, eroding trust of public health. Trust is fragile at this moment with institutions. Again, that's going to hamper our ability to get a lot of big things done. So that's a quick snapshot. There's a lot more insight that we gathered from all those data sources, but that gives you a quick insight as to what our community told us were our top health needs, as well as for us as an organization where we have the most opportunity. So with that, I'm going to turn it to my colleague, Ashley Young, and she's going to share with you how we're making sense of all of that and where we are going. Ashley?
Yes. So good morning, everyone. My name is Ashley Young. I'm Vice President of Policy and Engagement at Interact for Health, and I'm very excited to be here with everyone today. So we've heard from Kelly, we heard from Ross, a lot about what we've learned from people and data. And so now I'm going to share a little bit of how we're putting all of this information together and informing the direction in which we'll move forward. So I want to say, like, where we're going, we're still on the journey. We are still working through all of this. And so all of the things that we're sharing with you today are just pieces of information that we're using to help inform what our future work looks like. And so we haven't made any decisions yet of being concrete, but more so these are the areas that we just want to dive a little bit deeper and have a better understanding. Slide. So Interact's role, and Ross really talked a lot about this too when we did our SWOT analysis. And so when we think about what is our unique value add in the community, and how can we show up? And so being this neutral convener is a space where we really feel like there is a really great opportunity. So when we think about the issues that we want to address, and we talked about the importance of really looking at root causes and systemic issues, we can't do this work alone. And so really being able to convene folks across the region and really have an intentional focus in on collaboration and also trying to tackle these hard issues. I think when we think about trying to address systemic issues and policy approaches, when we think about doing it ourselves, it doesn't seem feasible. But when we think about the collective efforts of all the organizations within our region and community, it seems a little bit more manageable. And so how do we leverage our ability to be this neutral convener and really opportunity to convene maybe unlikely partners? Our role as a trusted, proactive, nonpartisan policy voice. So we're not going to get to the changes that we need to see from only just thinking about programs, and there's an opportunity to really just be strategic and leverage our unique value add within this space and really having a strong opportunity to speak as it relates to policy and advocacy issues. Being the go-to resource for data and health equity within our region. And so one, there's an opportunity to really just say, like, how do we know that we are addressing health equity? What do those measures look like? And how can we look at this over time? And so we feel like we have a really strong research and evaluation team. And so how are we able to leverage the data and stuff that we already collect and expand that to really make sure that we're able to measure health and health equity as a region? Flexible and catalytic funder. And so Ross mentioned this when we looked at our SWOT analysis, we have a unique position in where we can offer more flexible funding and we can take risks that might allow us to be catalytic in different spaces. And so how do we really identify what those opportunities are and lend our flexibility to those areas? And so these are just some roles that have emerged as we've going through this process, and we're going to continue to kind of dive a little bit deeper into what these roles mean for the community and how we're able to show up and add this unique value add. priority populations. And so as we were having community conversations, as we were looking at the data, we wanted to be just very intentional as we're moving forward in who are our priority populations. And the priority populations that we saw from the data are communities of color, particularly Black and Hispanic residents, our rural communities, and children and youth and families with low income. And so as we are going through this process and continuing this journey to really figure out what our next strategic areas and opportunities look like, we're really keeping these priority populations top of mind because these are populations that are experiencing inequities, and we really want to be intentional in our strategies to make sure that these priority populations are prioritized. All right, so emerging strategic themes. So again, this is a journey that we're on to really figure out what our work looks like moving forward. And these are the areas that have emerged from the conversations that we're having with people when we think about our unique value add, when we think about the data and where the opportunities are. So we have on the left-hand side, advancing health equity. And so when we think about our mission is promoting health equity. And so we really feel like we have a unique opportunity to elevate health equity as a community priority and really support collective action in addressing underlying health-related needs. And so that's an area that we're diving deeper in. Some emerging areas, I'll call them areas, under this topic is really looking at leadership and engagement. And this is really about community and how we are listening to community and really the importance of really building community power. The other area is data. So I mentioned this before around data. There's a unique opportunity for us to really, like, when we say health equity, what does that mean? What type of data needs to be collected? And so we're exploring what that looks like. And then policy and communications. We talked before that we're not going to be able to address the systemic issues and root causes just only by looking at programmatic ways. And so there's a huge opportunity to look and see what policies and systems need to be addressed, and also communication and how we're able to shape narrative within our community. And so that is one area that we're diving deeper. And these are some of the additional topics that we're also taking a deeper dive to really flesh out what the unique value add is for us in this space. The other area is improving mental health and well-being. And so we've seen a lot in the data that we discussed today that this is a huge issue. Mental health and well-being was already an issue before COVID-19, and we see that it has continued. And so when we think about improving mental health and well-being, we're exploring areas of resilient and thriving children and youth, and looking at recovering and flourishing adults. And so we're diving deeper in these areas to really see where are we seeing most issues within our community, and where can our unique value add be helpful. Both of these areas are really anchored in an approach of community-led efforts. And then this is really our core of really trusting community to lead and drive structural change. And so this is an approach that we're looking at exploring just as a foundational approach in advancing health equity and also improving mental health and well-being. And as I mentioned before, this is all emerging. And I want to say that again, that this is emerging. And so right now, as a team, we're continuing to just dive deeper within these areas. We're going to continue to look at data. We're going to continue to talk to partners and community members as we're starting to just figure out what our unique value add can be within these areas that I just discussed today. So next, discussion. So we have said a lot today. We've been able to share with you what we learned from our data, what we learned from people, and then also a little peek at where we're going in some of the emerging strategic themes. And so I just want to open it up. I think we do have time to take a couple questions, and also want to make sure that people can drop your questions in the chat as well. Any questions?
I just want to thank you for your thoughtful process and opening this up for us to hear. And mental health, of course, is a major concern, as well as the disparities. So I appreciate the focus that you have put forth.
Thank you so much. We have some comments in the chat saying agree that affordable housing is a #1 priority. People appreciate the robust engagement. Any other questions or comments that people have? And I'll also add too, as I mentioned, like these are emerging areas, and there's going to be opportunities for us to co-create some of this together as well. As you've seen, like we're not just doing this work in a silo, but really want it to be a collaborative effort between us and community. We're quiet. We'll go ahead. I'm going to hand it over to Kate to talk a little bit about our next steps. If you continue to have questions, please go ahead and drop them in the chat.
Thanks, Ashley. And I do see we got a question from Blair, or for Bryce, about when grant RFPs might become available. Great question. We don't have the answer to that yet. It would be later this year or early next year. Likely, I think we should have updates on that at our next webinar. I would say the next quarterly one in October. I believe it's the 14th. And but definitely stay tuned through Health Watch, and we'll push that out. I will say we were talking about how do we, in our RFPs and in our collaboration, and it's one of the things we've done in the past too, is really create learning networks where we are working on a collective challenge together. How do we facilitate that? And how do we be less prescriptive as a funder around solving this specific thing, and more listening and saying, the communities that you're serving, here's the overall goal that we're working towards as a region. How can you contribute towards that? So that's kind of what we're trying to figure out too, is how to do that. How can we provide funding that's more flexible, aligned to overall metrics, and also use that as part of building a learning collaborative and network. See some more comments and questions coming in.
Be helpful. I guess as isolation versus connections, relationship to poor mental health as solutions. So asking, is that kind of the direction that we're looking to go into?
I'll just jump in on that. Great point. I think it's key, right? I think it's a key part of it, and COVID, of course, exacerbated any underlying loneliness or isolation through literal social distancing. So I think part of our solution has got to be finding ways for everyone to create stronger connections and to have a trusted person in their life. We turn to all of you to think together about how we can foster more of those connections. Just reminds me of, I was literally just yesterday listening to a podcast by our Surgeon General, Vivek Murthy's a tremendous leader, and as many of you might know, there's a lot of tremendous research around loneliness as a key underlying factor leading to mental and physical health challenges. So I think that's an area where we can get creative around ways to create more connection and combat the isolation that many in our community are facing. Appreciate that comment.
We have another question from Stephen Wagner. To what extent would Interact for Health see itself as a convener? One of the efforts you might consider is identification of policies that continue or reinforce structural and institutional racism.
Stephen, thank you so much. Oh, go ahead.
No, you go, Ashley. I'll chime in.
Thank you so much. And I think that we would definitely consider ourselves a convener around that, because I think, as we mentioned before, and Kelly did in her presentation and talking about, like, those are root causes of a lot of the health inequities that we see. And so I think that could be potentially an opportunity. Kate, did you want to add to it?
Yes, just that I think this is an area in policy and advocacy where we as an organization see a lot of opportunity, having a clear policy agenda around equity, also around mental health and well-being. Where can our voice really make a difference? We're learning from a lot of other health foundations across the country that have been much more proactive in this space. We as an organization cannot do lobbying ourselves, but there's a lot we can do around education and being a neutral, nonpartisan policy and advocacy voice on some of these key issues that get at the root causes. And I really think, if our overall goal is lasting change at scale, addressing some of the underlying policies that are leading to these inequities is critical.
We also had a comment from Sam Lobar. Funding to help in upkeep of low-income housing in order to keep it affordable for residents and perhaps allow them to save in order to eventually purchase these rental homes themselves would be great.
Thank you, Sam. I think that's great. I think we are definitely, housing is one of the top, as you clearly know, health-related social needs, and came through very clearly in our conversations. There are a lot of efforts going on in the space, which is really encouraging. I think one of the areas we've talked about as Interact is how can we help the health sector plug in to those regional efforts around affordable housing, and both in terms of, look at ways where folks in the health sector, instead of duplicating efforts, how can we make them go faster? How can we help plug funds into those? We haven't figured out exactly what our role in that space will be, but it's very clear that that is critical if we are going to get to some of the root causes of these issues.
We had a question from Marilyn Crumpton. What about needs for dental access identified?
Happy to chime in on that. We saw it both come out clearly in the community health needs assessment. Dental access came out there, so we've been pulling that into what we're learning from, and there are great efforts in our region around that from the CHNA. And then also, we shared some of our stakeholder survey insights, and one of the priorities for folks who live and work in our rural communities was dental access.
And just building on that, I think one of our themes of this is for those populations of focus that have the greatest inequities. So the rural communities are communities of color and low-income families. And I know, Maryland, especially in the rural areas, this does continue to come up. And there are still pockets in our urban areas where this is a major issue. So where the community is identifying this as their issue, part of our health equity focus is really being responsive to those communities that are furthest behind and where that is an acute need for them.
We also had a question. Have you identified needs for funding prescription meds or retrofitting older adult homes so that they may stay in their homes longer? If so, how are you funding?
Prescription meds has not come up outside. I think one of the huge policy opportunities there is there's federal legislation that is needed to allow for a government to negotiate on prescription drugs that would have a ripple effect in every community in this country. So I think that is part of it. I think we have in this area, both in Northern Kentucky, and then also through the St. Vincent de Paul Free Pharmacy in the Ohio area, really listening to them about where are the needs that they're seeing in this region and what are the gaps to fill there. But it wasn't something that came up a ton in conversations. And so I think we would want to dig in with those partners to understand where the needs are and how can we help support that.
Jocelyn asked, wondering if anything was revealed about racial disparities in service and care for those with developmental disabilities.
I can go. I don't think that we look specifically at developmental disabilities. I know that we had a lot of people expressing through our community conversations just not having culturally competent providers. But I know I don't think we've looked specifically at developmental disabilities.
We just say we welcome Jocelyn conversation and data and anything that you would like to share on that would be helpful to us would be wonderful.
We also got a question. We keep hearing from people of color that it is a struggle to find culturally sensitive care for substance use disorder and its comorbidity with other mental health problems. Might convening a meeting or two helping to link harm reduction groups and providers that can provide this care be a possibility?
Ross, I don't know if you want to chime in on this, but thank you, Linda. This is definitely a theme that has come up around the opportunity, and we've heard it too from patients, from parents who are trying to navigate the lack of connectivity between some of the substance use misuse treatment and also mental health. There is such a need and opportunity for greater connectivity there. And so I think it's a great suggestion to have some conversations around what's needed there. And I'd love to follow up with you on that.
We also got a comment from Gregory Stewart. Encourage you to consider addressing high evictions in counties and demographics of those of who is evicted. What % of eviction is connected to racism? What % is connected to mental health?
Thank you, Gregory. You are highlighting a passion of mine, which is I think there's a lot of data that could be really powerful. Powerful at many levels to inform sort of the decisions like you're highlighting and understanding the problems that we're tackling, and powerful for communities to see. So I am not sure the extent of what data is available around the evictions and getting to race data on that, mental health conditions, but I think we've had a number of internal conversations around how can we bring together data sets, make them easily accessible, transparent to communities and to all of us as partners who are working on these challenges to help inform our decisions and particularly bring it forward to communities to see this. So that's a great suggestion and really appreciate it. And I do realize we're at time. I am also a stickler for finishing a meeting on time. And so please feel free to put additional questions in here. We can follow up individually with those as well. And I see, Marilyn, you did drop a question about school-based health centers, and that kind of goes back to what we were saying with dental. We are, certainly looking for, would welcome the opportunity to expand and build and strengthen school-based health centers, particularly in those communities that have the greatest inequities and where it is a priority for those communities. And here, this is our final slide, just to share that we are back with our next one on Friday, October 14th. Please go to our website under What's New, Strategic Planning. You can register for the next one to get an update on when that, with the link. And we will really appreciate everybody making the time to join today and look forward to hearing and listening and engaging as we go forward in this, because we're in this together, and really appreciate your partnership throughout this process. So thank you very, very much. We really appreciate it.
Bye.